Today I will discuss how USC in Thailand was designed and contribute to equity and efficiency. Thailand USC reform date back in 2001. It has substantially increased healthcare use, especially among the previously uninsured. In 2009, the program had already reduced by more than 300,000 number of people suffering from catastrophic healthcare costs. This is the decision by the country against the concern by your colleague in the bank that it will be fiscally unsustainable, and we survived 15 years. These are the three outlines that I will talk. Thailand is an upper middle income country with high level of health achievement in terms of life expectancy and mortality outcomes. USC has been achieved since 2002 with comprehensive benefit package and almost zero co-payment at point of services. Healthcare expenditure is less than 5% of GDP, and OOP is very low, 11.3% of total health expenditure by World Development Indicators, while public expenditure was 80% of THE in 2014, which increased from 56% in 2001 prior to UC. GGHE, General Government Health Expenditure, is 17% of GGE. Declining child mortality trend was noted. It is on par with high-income non-OECD countries and much lower than upper middle-income peers. We achieved 12.6 under 5 deaths per 1,000 live births in 2015. U5MR in this graph is so exciting to see. Both X and Y axis are the relative performance of child mortality compared to predicted child mortality from regression analysis throughout the world. So the observed figures minus the predicted figure will show the relative performance in relation to GNI per capita on X-axis and in relation to THE per capita on Y-axis. The left lower quadrant shows countries having above average performance as their child mortality is lower than the predicted value, and that Thailand located in this lower left quadrant. Similarly, MMR in Thailand is relatively above average performance. Thailand located in the lower left quadrant in relation to the THE per capita and GNI per capita. In addition to health status performance in the previous two slides on under 5 and MMR, the supply side in terms of hospital beds in Thailand is also relatively above average. Hospital beds are lower than the predicted value given the THE and GNI per capita on the X-axis and the Y-axis. So this is the global peer. You see one of the outlier on the right, far right upper quadrant, which is Japan. They have too many beds per 1,000 population. Also, health workforce in Thailand is relatively above average. Doctor, nurse, and midwife per 1,000 population are lower than the predicted value given the THE and GNI per capita achievement in Thailand. Our pocket payment as percent of total health expenditure. The trend between 1995 to 2013 from WDI or WHO National Health Account, the OOP has substantially reduced from around 30% of THE in 2001 prior to UC to less than 11 to around 11.3% or less than 12% of THE in the most recent year in 2014. This is on par with high-income OECD peers. On fiscal space, between circa 2000 and 2010, fiscal space in Thailand is on par with upper middle income peers. However, this figure is still lower than the high income OECD countries. Government revenue was around 20% of GDP. It is quite conservative without change in the past 20 years. So that means with a quite substantial health achievement, health indicators, and resource input in terms of beds and human resource per thousand population. That means country like Thailand should have a very high and very lean performance in terms of health systems. Next, move to health, fiscal space for health in cross-section in 2013. Fiscal space for health is measured by general government health expenditure as percent of general government expenditure, GGE, was above average compared with countries having similar GDP per capita. This demonstrates, I don't know whether chicken or egg, between UC and fiscal space for health. But I would say USC trigger and maintain the high level of government spending on health, a major achievement much higher than the Abuja Declaration of 15%. It is a long march indeed. We spent 27 years since the first launch of free care for the poor in 1975, when the income of the country was only $390 per capita. Compared to India, you have $1,500 per capita today. We implement low-income scheme free for the poor since 1975. Thailand covered the whole population when the GNI was merely $1,900 per capita. And at the bottom of economic crisis, not fully recover from 1997 Asian economic crisis, actually triggered by Bangkok. Today we have three schemes: the government employee scheme, which is tax finance, social health insurance, which is payroll tax finance, and the remaining of the population, which is a tax finance. So the total financing source is more or less dominated by tax finance scheme, and that with a decent high comprehensive benefit package, the catastrophic and health impoverishment is quite low. UC was achieved because it is a political decision by Prime Minister Thaksin Shinawatra, because he committed in the general election in January 2001 manifesto that we will go with UC. Therefore, we published a paper that it is totally a political decision whether a country will move or not move to a UC. Now, what are the UC achievements? Despite political conflicts in the last 14 years, UC flourished across 8 rival governments, 7 prime ministers, and 13 health ministers, and have been working with all these 13 health ministers, and also work with Prime Minister Thaksin on the design and support how should we implement the UC with a good outcome. I was involved as a participant observer, involved with the design since 1991 social health insurance design, and also 2001-2002 UC scheme design. Empirical evidence show positive outcome of UCS in all dimensions: pro-poor utilization, pro-poor benefit incidence as measured by how much government subsidize go to Q1 or Q5, the poorest or the richest quintile, and minimize medical impoverishment, gaining efficiency and cost containment. These are the published paper. It is very interesting how USC march out through this rough politics. Incidence of catastrophic spending as measured by more than 10% of household expenditure on health gradually reduced more among the poorest quintile than the richest quintile. Counterfactual on the dotted line above line. If there were no UC scheme, there would be this amount of household impoverished from medical bills. The solid line, the lower line, is the observed lines from the National Household Survey by National Statistical Office. The gap between the dotted line and the solid line is the net number of households being prevented from impoverishment because of medical bills. And if you see 11.2 something of THE is our pocket payment. Therefore, this confirms each other. Improved utilization both outpatient and inpatient was noted. IHPP worked with National Statistics Office to monitor utilization through National Household Survey, unmet healthcare needs using standard questionnaire surveys applied by OECD. And we find that the unmet need was very low, on par with OECD countries. District health system consisting of health centers for a catchment population of 2,000 to 5,000, and the district hospital for 30,000 to 80,000 population. District health system is functioning due to mandatory rural health services by all new graduates, nurse, medical students, dentists, and pharmacists, which was introduced date back to 1972. So that is more than 40 years that we implement mandatory rural retention, mandatory rural services. In addition, policy to recruit rural students from health professional education and hometown placement have shown very effective on retention of these health workers, and it makes district health system functioning. As a result, we note shift of service utilization from tertiary care hospital dominant in 1977 and gradually to primary care dominance in 2010, which is a major achievement for the Thai health system. The UCS contract district health system as a major contractor provider network, also as a primary care fund holder for outpatient services. DHS, namely health center and district hospital as a close-to-client services, is the major hub in translating UC scheme policy into a pro-poor utilization as measured by concentration index. The minus sign of the CI demonstrates utilization is in favor the poor and vice versa if a positive sign is in favor of the rich. Private hospital is catering the rich section of the population. Then what are the contributing factors? It's a continued political commitment to UC scheme. Budget used to subsidize UC scheme increased from 1,200 baht. If you divide by 30 baht, it will be $40 per capita for a very comprehensive. Everything is included except a few exclusion lists. For example, aesthetic surgery or proven ineffective interventions as guided by the Royal College. It has increased to 3,100 baht in 2014, almost 3 times increase. This is a result of increased utilization rate of OP and IP, expansion of high cost but effective new interventions into the basket of package, and the cost increase in particular 4% salary increase and 2% medical inflation. So the overall increase due to these contributions. The merit of cross-end provider payment applied by UC scheme is cost containment. I would reiterate, cost containment is so critical because China, Philippines, Vietnam are suffering from applying fee-for-service without effective control. Someone may argue that Japan also use fee-for-service. It's not true. Japan use a global budget, but use a fee point system similar to Taiwan. Capitation is used to pay OP services. Global budget and DRG is used to pay IP services. This payment method sends strong signal to doctor and hospital towards efficiency and to keep the margins. The downside of the potential under provision of services was fully captured and addressed by complaint management, accreditation, and audits. Benefit package in 2002 was comprehensive, where negative list is applied with a small list of exclusion. Later on, renal replacement therapy is exceptional. It is cost ineffective, but it is catastrophic and impoverished to the household. Dialysis was included in 2006 due to ethical and equity consideration. Otherwise, today, new intervention medicine services to be included into the benefit package are subject to stringent HTA, using incremental cost-effectiveness ratio of less than 1 GDP per capita for one quality-adjusted life year gain. So all these are homegrown capacities that we built up. When HTA was fully applied, it seems we practiced this since 2008. We don't have capacity to do HTA since day one. Then that means we sail the boat. We know the boat has a patch hole, but we have to off the harbor and sail in the wind, and we mend the patch hole. It seems that there is a cascade level of coverage decision. First is cost effectiveness cut, followed by budget impact, and finally health system readiness to provide new services and other ethical equity consideration. If cost saving with low budget impact, decision is yes, go. For example, lamivudine and the treatment of lupus nephritis. If it is a cost saving and low impact, budget impact, but limited capacity to provide services, decision is no. Is no. For example, implant denture, it will create inequity because people in Bangkok and major city will enjoy this benefit, denture implant. If cost effective, but budget is so high, decision is no, such as treatment of hepatitis C and adult diaper, to name a few. Monopsonistic purchasing, where a single buyer, which is National Health Security Office managing UC scheme, purchase goods and services from multiple sellers or even a monopoly products or oligopoly products, has a high potential for cost saving given actual quality. NHSO managing UC scheme had demonstrated its capacity in negotiating price down, with a total cost saving of $188.3 million during the period of 2009 to 2012 among this either medical supply, drug cost stent, medicine, erythropoietin, and CAPD solutions. UC scheme was implemented in the context of a mature, extensive geographical coverage of functioning supply side. Indonesia, Jack, you know very well. They implement in haste early last year, 2014, this year. And inequity increased because Java got all the high-tech and hospitals, beds, equipment, and specialists, whereby in many eastern part of the country did not have that services. Therefore, this is a critical message. It is a result of 3 decades of health infrastructure investment. District health system facilitate access and the main hub for poor outcomes. Cross-end provider payment contribute to efficiency and cost containment, and comprehensive package result in high level of financial risk protection. Equity goals and efficiency goals are achieved through different policy intervention as described so far in the previous slides. If you look at the boxes, equity goals here and efficiency goal. And these are the key intervention that my 2 cents sharing with you should be useful. As UN Secretary General Ban Ki-moon referred to Thailand experience, he went to see and spent 3 days in the field and see by his eye, and he said, in one of his speech. You don't have to wait to be rich to provide these health services for the people. I listened carefully this morning. India is rich enough. You have resource enough. And the GNI per capita today is $1,610 per capita. It's not that small, and you have potential. You are classified as a lower middle income country group. I would conclude that political commitment make the impossible you see possible things. Thank you for your kind attention.